Home is a place where most of us feel completely safe and comfortable. For some elders, however, home is not a safe refuge. Behind closed doors, these older people are victims in the tragic drama of elder abuse. Elder abuse is the mistreatment of an older person by someone who has a relationship with the elder. It could be a spouse, adult child, friend, neighbor, or caregiver. According to the National Center on Elder Abuse, more than 2/3 of the abusers are family members. Elder abuse can happen to anyone, by anyone, regardless of his or her social class or ethnic background. The results of elder abuse can be seen in the unnecessary suffering, injury, and violation of human rights of the elderly. Hello, I'm Marian Karpinski, and I'll be your host during this program. Elder abuse can happen anywhere. It can happen in group homes, such as foster homes, nursing homes, or assisted living facilities. In this program, we will address elder abuse in the elder's family home. Elder abuse can be difficult to identify. Some diseases and chronic illnesses can mask or mimic the visible signs of abuse. For instance, some diseases may cause people to bruise more easily. Weight loss may be a symptom of a disease, a caregiver's failure to provide adequate meals, or an elder who refuses to eat nutritious meals. Elder abuse is very complex. Generally, a combination of factors contribute to elder mistreatment. Abuse is often inflicted in a subtle way, especially if it's premeditated and deliberate. Abuse can be the result of a history of family violence that continues into the person's later years, or violence that begins with a new relationship, such as marriage. Violence is a learned behavior that in some families is passed on from one generation to the next. In these families, abusive behavior is their normal response to life because they have not learned other more appropriate ways to respond.
Talking about the learned behavior and the learned violence, I think that it's very important to understand that we all grow up learning how to behave in a family from the family we grew up in. And if corporal punishment and if verbal abuse is part of a person's upbringing and they come up having that be the norm, I think it follows through and translates into older age, that the child who was verbally abused is now going to use that same verbal abuse on the elderly mom or dad who is now bedridden or wheelchair ridden, and think nothing of it because that's how it's done in this family. Unfortunately, I think that it then escalates because the response from the elder is usually nothing or very little because of their fear of making a bad situation worse. And so the frustration coupled with the learned behavior is a recipe for it getting worse. We know abuse gets worse. It does not get better.
Elder abuse may happen because the abuser suffers from mental illness or from problems such as alcoholism, drug addiction, and financial difficulty that makes him or her dependent on the elder for support.
If there's an abuser who tends to use drugs and alcohol, what we know is that that can give them, first of all, the permission to go through with the abuse, and secondly, it will accelerate it to possibly make it more dangerous and greater than it could have been.
Another contributing factor that results in elder abuse is caregiver stress. Not all stressed caregivers are abusers. For some people, the demands of caring for a frail older person, the absence of financial resources and support, and the lack of caregiving skills may lead to abuse or neglect. Without meaning to, a caregiver who lacks proper training can cause bruises, skin tears, and broken bones in the process of moving and positioning an elder.
one of the most common things that we see in elder abuse is sometimes what we misconstrue as caregiver stress, when truly what it is a continuation of family violence, domestic violence, that has probably happened in that relationship for a very long time. And now here we are as family members or healthcare providers, and we have a spouse who's coming to us and saying, you know, it's so frustrating to be the caregiver here because it's just so stressful, and I just am at my wit's end half of the time. And if we say to that person, well, I understand how it is, I really do, it's a very stressful situation, and we are somewhat giving permission for that to continue. We're justifying the abuse because of the caregiver stress.
Ageism is a form of prejudice against older people based upon negative images and stereotypes. Ageism increases the risk of elder abuse. The abuser uses these prejudiced attitudes to justify mistreatment of an elder. The definition of elder abuse varies from state to state, but it is generally agreed that the forms of elder abuse include physical abuse, sexual abuse, emotional or psychological abuse, financial exploitation, neglect, self-neglect, and abandonment. It is important to know what signs and symptoms to look for in identifying each form of abuse, because the abuse is often well hidden by the victim and the abuser. According to most state statistics, neglect is a leading form of elder abuse. Neglect typically means the refusal or failure to provide the necessary care to an elder by someone who has assumed that responsibility. It includes the refusal or failure to provide an elder with life necessities such as food, water, shelter, clothing, personal hygiene, medicine, and personal safety.
What caregivers need to remember is that if they are assuming the role of a caregiver, and this could be a paid position or an unpaid position, that they have a certain level, a certain duty to perform their activities with the older person, which in many instances is a family member. I would urge people to understand that the states are becoming more proactive now when they're dealing with neglect situations. And in some instances, a neglect situation of an elder person, failure to provide food, not turning the person in a bed, which could result in, say, bed sores or decubitus ulcers, could rise to a criminal level. And in many states, there are prosecutions taking place now on this specific form of elder abuse.
Some of the signs and symptoms of neglect include unsanitary living conditions, such as a dirty home, fleas, the smell of fecal and urine odors, soiled linens, or lice on the elder's body. Other signs include untreated bed sores, poor personal hygiene, dehydration, and malnourishment. Unsafe living conditions, such as no running water or heat, are signs of neglect. Neglect can also include the failure to pay for home care services by a person who has financial responsibilities to provide care for an elder.
Self-neglect is another form of neglect, and this is when an elder person who's taking care of themselves does so at a risk to their health and well-being. For instance, an elder person may not be feeding themselves enough, may not be hydrating, taking enough medicine, or taking too much medicine. What about their general living conditions? They may be living in a very dirty environment. And this is another form of neglect that we need to be very cognizant about.
Unintentional neglect may occur when the person assuming responsibility for care is incapable of providing that care.
When I first came here, I realized that my stepfather had dementia and he was getting worse. And my mother has had a problem with her knee and her hip, which turned out to be her heart and her lungs. And my mother could no longer care for my stepfather. And my stepfather could not care for my mother. They both needed care. They both needed help, and we didn't know where to turn at that point.
Financial exploitation is a very serious issue as it relates to elder abuse, because as people age, they need to keep their monies for taking care of themselves, providing food and shelter, and also medicine. And there are some people out there that are intentionally trying to rip off seniors, whether they're friends, caregivers, or even fraud scam artists. And some things to be mindful about when you're dealing with financial exploitations. Who's got the check writing authority? Is it the senior citizen, or is it perhaps a caregiver that has been able to get their name on the bank registry? What about other legal documents, power of attorney, the sale of property or deeds or trusts are issues to look at as well.
Look for sudden changes in bank accounts or unusual banking practices, such as a withdrawal of a large sum of money. You may want to check the elder's bank signature card. This will alert you to any additional names that may have been added. There may be an unexplained disappearance of jewelry or personal property. The elder may complain of missing articles or money. Caregivers or family members may gain unauthorized access to the elder's ATM card and withdraw money from the elder's account without his or her knowledge. The elder who is bed or wheelchair bound or who has dementia is more vulnerable to this type of financial exploitation.
And also seniors are vulnerable to the regular scam artist, the door-to-door salesperson, for instance, who wants to sell a new roof, or the telemarketing person that intentionally targets the senior citizen because of their trusting nature and perhaps the availability of funds which they may have.
Emotional and psychological abuse really is one and the same thing. It is when an elderly person is being spoken to in a derogatory manner, is being told that they are stupid, that they don't know what they're doing, that they are a bother, when the person who is giving care to them withholds things that they need, like medication, clean clothing, clean bedding, affection, food, attention. When the elderly person is made to feel as though they don't count, that their needs are not important, and that they are in the way. We find that often emotional and psychological abuse, verbal abuse, can be more damaging over a longer period of time than physical abuse can be. And we have found that to be so. And it drives the person who is being abused inward, which is what keeps them isolated and keeps them from getting help and encourages the abuse to continue.
Physical abuse is defined as the use of physical force that may result in bodily injury, physical pain, or impairment. Hitting with the hand or an object is only one form of physical abuse. Pulling hair, pushing, shaking, kicking, pinching, and burning include other forms of physical abuse.
There was one time when I walked in the room and he had raised his hand, backhand, to my son. And my son is 4 years old. And my son was like this, with his hands up against his face, in fear of what my stepdad was going to do to my son. And of course, I stepped in and stopped that. But what was so sad was the dementia had made him very unpredictable. And at one point, when he had had a stroke, the nurses had even told my mother to hide the knives. He had taken knives to some of the portraits that he had done of my mother.
Force feeding, inappropriate use of drugs, and physical restraints are other examples of physical abuse. The signs and symptoms of physical abuse may be bruising or finger mark bruising on the arms or legs. Black eyes, welts, and rope marks are other signs of physical abuse. Broken bones, sprains, dislocations, open wounds, cuts, or punctures may indicate physical violence against an elder. It is important to look for signs and symptoms of abuse in areas that are not as readily visible as the face and arm, such as the stomach and back. Some abusers deliberately choose those places to hide the abuse.
Sexual abuse is a kind of abuse that we overlook in elderly people often because it is particularly shameful to them, so they don't reveal it to us as often. But sex abuse in elderly can include things like unwanted sexual contact, sex without being able to give consent, as in the Alzheimer's patient or disabled person, forced intercourse, any kind of sexually degrading acts that are against the person's moral belief. We see these things more commonly than we want to believe.
Of all the abuse, the sexual abuse of elders is something that they are very reluctant to talk about. Oftentimes, elderly women do not think that when a male child or grandchild or caregiver says something inappropriate to them that is sexually inappropriate, that there's anything wrong with it, because they come from a time and a belief system where men were given the right to speak to women in certain ways, and they don't think there's anything off color or wrong about it. But often that leads to further abusive situations. I think that it's very difficult unless there are outward signs like the obvious vaginal infections or bruising in the area or what have you, that a person really can tell when there is sexual abuse, unless the person who is being abused begins to give you clues. Oh, well, they want to always be in the room when I'm changing my clothes, or he insists on coming in the bathroom and staying there, and I ask him to leave, but he stays, and those sorts of things. Little clues that we need to be so aware of and pick up on and begin to ask more about.
Other signs of sexual abuse may be a change in behavior. For example, an elder who becomes severely upset when being bathed, dressed, or undressed. Torn, stained, or bloody underclothing, or unexplained vaginal or anal bleeding may also be signs of sexual abuse.
Deserting an elder person by a person who has assumed a level of care or duty of responsibility is called abandonment, and that's another form of elder abuse. A famous case that took place several years ago was when a caregiver, a family member, took their father to a neighboring state. This individual had Alzheimer's and was confined to a wheelchair. The caregiver put this father at a racetrack and abandoned the person with no intention of ever coming back. We see abandonment cases with a little bit more frequency now. Oftentimes the person is abandoned at a hospital or senior center or abandoned at a shopping mall by a caregiver with no intention whatsoever of ever coming back to get this person.
There are some general signs that may indicate abuse is occurring. For instance, the elderly person may complain of being mistreated. Watch for any sudden change in the older person's behavior. For example, a once very talkative person may suddenly become withdrawn and depressed.
The person who is being abused often is very reluctant to talk, is very shy and withdrawn. Upon inquiring if everything is okay in the household, will always say quickly, everything's fine, everything's just fine. When you begin to suspect that something might be wrong and you begin to push a little further, you will often notice that the abuser is in the other room listening to what is being said by the abused person. And as a result, the next visit you make will often find a reason for you not to come into the home. The closer you get to an abusive situation, the more there is to protect on the part of the abuser, and the abused person is more fearful than ever, and you will notice more and more agitation on their part because of their fear.
Abusers come in all shapes and sizes. No single characteristic identifies an abuser. An abuser uses whatever means possible to deflect attention away from the abuse. An abuser may be
someone who was unwilling or would be finding excuses for the home health nurse, for instance, to come into the house, would be making excuses for why this person can't be there. They're asleep, or they're having a bath right now, or they're at the doctor, or they're at the dentist, or they don't want to see you today. You would find normally that this person is very short and doesn't want to engage in any kind of a lengthy conversation with you. Often will speak out the window or with the door just slightly ajar. They do not want to be confronted because they have something to protect.
Sometimes it's very hard to identify someone as an abuser. And the reason is because they're often very charming. People really like them. They have a good sense of humor. And they're often leaders in the community. Maybe he had a Boy Scout troop at one time, a leader in his church. Very convincing. An abuser is someone whose life depends upon their good manipulation, their good charisma with other people. And of course, behind closed doors, we know that there is an entirely different story here. First of all, we all need to get better educated. We need to understand the dynamics. We need to understand the resources in our community. We need to know what to do and to know all the warning signs. So that would be the first thing, is to really raise our own personal awareness. I think then as healthcare providers, another very important thing for us to do is to do some very good screening. When we ask the question, we will get an answer. When we ask about past abuse and present abuse, we'll get some insight into what is going on with this person and how their health is affected. And to do proper screening, we have to be very careful about this, very sensitive to the situation. In other words, you must provide that patient a time alone. And this could be the policy of your home health care or your hospital or facility, that every patient has that private time with his or her health care provider. So you can ask those questions in a way that makes it safe for them to say, yes, I am being abused.
listen and take seriously any complaints of mistreatment from an elder. Here are some things to keep in mind if an elder confides in you about an abusive situation. Do not bombard them with questions or interrupt with comments. This may be a very difficult subject for the person to express. Do not jump to conclusions or make accusations. Always respond openly, honestly, and with sensitivity to the elder. Any complaints of abuse from an elder should be reported to the proper authorities. One of the ways we can help prevent elder abuse is to provide family caregivers with education and training in proper caregiving procedures. Families also need support and respite services. We all have a responsibility to help prevent elder abuse, and one of the most important ways to do that is to report it. Most victims do not report abuse because of their shame, denial, fear, and isolation. They may be unable to report abuse because of physical disabilities or because of dementia, such as Alzheimer's. It is very important that we make the report of suspected abuse on their behalf. If the elder is in immediate danger, call 911 to make the report. Most states will take a complaint of suspected abuse anonymously. If danger is not immediate, you can report suspected abuse to your local county adult protective services, whose professional staff will make the investigation.
Adult Protective Services was there within an hour to counsel with us, to tell us what our options were. They heard that we wanted our stepfather to be cared for as well, and what was so great about it was it ended up where my stepfather got the help that he needed and deserved, and my mother is cared for and has dignity, and there's peace in our home.
If you have difficulty finding your local Adult Protective Services number, you can call the National Elder Care Locator number at 1-800-677-1116 and let them know you want to report suspected abuse. They will let you know the number to call in your area. Many states have mandatory reporting laws for professionals who work with the elderly. If you are a mandatory reporter, and most health professionals are, follow your state guidelines for the proper procedure when reporting suspected elder abuse. The drama of elder abuse need not end in tragedy. When you become an elder's advocate, you break the cycle of isolation and secrecy that is at the heart of elder abuse. You may be the one person who can make a difference. Your involvement may be the key to restoring peace and safety to an elder's life. Use the resources available in your community to report suspected elder abuse.
That way, when they want to reprimand them.
Being aware of your gestures and how you are communicating nonverbally is important to cultural competence. People may respond to offensive gestures with expressions of anxiety or discomfort. Ask if you have done anything to offend that person and be willing to apologize for your actions. This will help to keep communication open and to reestablish trust. Books are available that teach appropriate gestures for each culture. 2 of these books are listed at the end of the video. Other factors that influence the quality of health care are gender roles, language, and literacy. In some cultures, women are extremely uncomfortable being examined by a male. Successful treatment of women from Muslim or Asian cultures may depend on matching them with a female physician. In some cultures, men have a difficult time trusting a female healthcare provider. Language differences can be a barrier. If English is not the primary language, a translator may be necessary to assure quality health care. Family members may not understand how to convey medical terms. Always use a professional translator whenever possible. Do not assume that clients can read. Never rely on only written instructions or assume that written material will be read if you leave it with someone. How much space people need around them in order to feel comfortable is culturally determined and learned very early in life. In most social situations, Americans maintain a distance of about 30 inches. Latinos, Africans, and people from some Middle Eastern cultures can be much closer to each other, while people from Great Britain require more distance. Gender, social rank, and authority also affect what distance people from different cultures consider appropriate. Developing awareness about the importance of personal space is part of providing culturally competent care. The definition of appropriate touch varies from culture to culture. Italian and Central and South American people tend to be highly tactile. Each culture has its own standards that define when touch is considered polite or appropriate. Every culture also has its own taboos regarding touch.
If you touch somebody else's head like this, or we can touch friend like this, but for Vietnamese, if you don't know them well and you touch, or even though in some cases they know well, we know them, you know them well, but you touch them and they may get angry because for Vietnamese, and I would say that other Asian people, they think that their head is just to worship. They use their head as to worship their ancestor, or it's a very sacred thing that that's untouchable.
Even something as simple as giving a bath, particularly if you are in home care. There are quite a few cultures that have strong feelings about you can't touch the feet and then go touch the chest or touch the head. So if you're going to be giving a bath, you need to go from head to foot, or some that don't want the head of, say, a baby touched. And I'm thinking in terms of what I'm used to of, you can't feel, say, femoral pulses and pedal pulses and then go and listen to the chest. This is a taboo. So again, trying to find out if there's, asking the patient, how would you like me to proceed with giving your bath? What parts would you like me to do? And that's where you would pick up the clues that maybe it's important, maybe it's not important.
People will often give clues about their preference for personal space and touch. When you sense someone withdraw from touch, you can take that as a cue to behave in a more formal way, mirroring that person's behavior. If you feel as if someone's invading your personal space, remember that personal space is culturally learned. You can choose to move away, or you can honor the interaction with that person by suspending your own cultural preference. Cultures measure and respond to time in different ways. In America, we value efficient time management. In healthcare, we make appointments and expect people to be on time. For some cultures, clock time is not as important. Finishing a conversation at a relaxed pace holds a higher value than being on time.
If you talk about the Mexican-American elder, there's some very important values. One of them is how you enter into the healthcare exchange. And you enter into it informally, talking to them about social irrelevant issues to the clinical setting, because that's what they expect from you. And then after you've dealt with that, then we can move on. And I'll give you an example, because I'm not sure that I'm making myself clear. In other words, if I were to come in your home, before I would immediately want to deal with your wound, or before immediately dealing with your diabetes, or before immediately dealing with your injection, I need to ask you how you're doing. I need to ask you how your kids are doing. I need to ask you about Maria that you told me was getting married last week while I wasn't here, and how was the wedding. And I need to ask you about your grandson Robert, who was sick the last time I was here, and you told me about him and how he was feeling. I need to ask you about all of those things because they're important to you. That's kind of like the important value.
It's important to take into account the different values people have about time. Expectations about meeting appointment times may need to be flexible and negotiated. Scheduling an appointment after a routine activity, such as a meal, may work better.
Because people's beliefs and practices around being sick and staying healthy may be different from one's own, we need to understand what theirs are and work with them. If, for example, one cannot give a patient that is just a newly arrived immigrant from another country, and I won't even say any country in particular, but say they don't even speak our language, and if they were just diagnosed as a diabetic, we just can't hand them the American Diabetic Association diet saying these are the foods you should eat, because they're not going to have those foods.
Each culture has its own food preferences and food taboos. Successful care of people from different cultures must include awareness of and respect for their traditional diets and food restrictions.
I remember one example where we were pushing a diet to build somebody up for surgery, and this was a person that had just recently immigrated, the food was so detrimental to their intestines, they just weren't used to it, that they had diarrhea all the time. So we were working against ourselves, so we made it worse. If we could have had the family bring in foods they were used to, that would have met everybody's goals better.
In many cultures, the family plays a large role in how people make decisions.
In the Vietnamese family, there are people that make decision maker. It could be the breadwinner. The breadwinner could be your son, or the oldest son. The oldest son would be the decision maker, even though he's not a breadwinner of the family. And parents sometimes have to listen to him in order to make decisions for the whole family. The role of the oldest son in the family is very important.
So then after her would come my oldest sister. She would be the decision maker then in the family. Just like my grandmother was the decision maker in the whole family, you know. If that's what grandma said, then that's what happened.
In some cultures, it's the husband that has the right to say if I have surgery or not. In others, it's the oldest son that is the spokesperson on health decisions. But you can't know all the cultures in the world, so you have to ask them who would they prefer that we talk to about the details of their care. Many times in our culture, we want to know all the answers, but that's not true in many other cultures. For example, in many Asian cultures, you never tell a patient that they are dying, and you don't give them all the details. You never give them the results of all the tests. You give that to the family spokesperson. And they decide how much information they're going to give the patient because they see that as their protective role of their mother or their wife. And we're interfering with that if we just blurt this all out.
Sexual orientation can affect health care in a variety of ways. Gays and lesbians may find it more difficult to locate open-minded healthcare providers because of stigmas about homosexuality or fears about AIDS. Medical decision-making is often more difficult for gays and lesbians than for others. If one partner of a gay or lesbian couple is in intensive medical care, the wishes of the significant other may be ignored because there is no legal marriage or because of family conflict or disapproval. When possible, the patient's choice for a decision maker should be honored.
If you're providing care to an elder from a different racial or ethnic group, there's some things that you need to be aware of. The first one is, as the person providing care, you need to know a little bit about yourself, your culture, what your beliefs are, and what your values are, because they're going to come into play when you encounter someone with different beliefs and values. So you should know a little bit about yourself and who you are.
To understand more about your own cultural background, ask yourself questions such as these. What cultural group do I belong to? Who do I go to when I am sick? Are there foods I don't eat because I consider them dirty or unhealthy? What are my religious or spiritual beliefs about health and illness? By becoming more aware of your own beliefs, values, and expectations, you can consider how these affect the care you provide to people of other cultures. Other questions to ask yourself are, do foreign accents irritate me? Do I believe that everyone should be able to speak English? Am I fearful of certain cultures or people? Do I assume to know what is best for the person I'm caring for? That I understand his or her wants and needs? If care providers make assumptions or expect certain behaviors from people of specific cultures, these stereotyped attitudes can create barriers to care. No one is ever exactly like the description of his or her culture.
In Indian culture, it's not always the same. She's a different tribe than I am. Mm-hmm. I'm a different tribe. And even the area from which you come makes a difference. I'm from the southeast. She's
South,
from the
you're
west.
from the South Plains, and I'm from the Northern Plains.
They had a different way of obtaining food, shelter. We had a different way. And also, when the Christian people came, they encountered us down there. We are Southern Baptists mostly. Where she lives, probably Catholic or Jesuit priests came out here. So all those little things make a lot of difference in the way we react in our adult life or to a situation.
There is a lot of variation within a culture, and there's even more variation. There's more differences between people within a culture than there are from one culture to another culture. There's just huge ranges. So all these rules, etc., are really just guidelines and signposts saying there may be something different here, but you always have to check it out with the patient, validate with the patient that this is what he or she would like you to do.
Cultural assessment tools help us to better understand cultural and ethnic factors that affect health care. Important areas covered in a cultural assessment include language, literacy level, communication style, food preferences and taboos, religious beliefs, beliefs about the cause of disease, attitudes toward Western medicine, and use of folk or traditional forms of medicine. Family members may not wish to disclose certain information to the healthcare provider for fear of disapproval. When doing a cultural assessment, ask questions that are open-ended and general in nature. These types of questions create an atmosphere that is non-judgmental and encourages the person to be more candid. For example, if you want to know who is providing medical care to that person, rather than ask, "Who is your doctor?" ask, "Who do you go to when you are ill?" Open-ended questions allow a person to feel free to talk about his or her medical doctor, spiritual healer, Chinese herbalist, or acupuncturist. Rather than asking someone, "What medications are you taking?" ask, "What do you use when you are sick?" This will allow that person to tell you about any medicine or therapy that he or she is using. Some herbal remedies can interfere with or potentiate prescribed medications. It's important to establish trust through open-ended questions to assure safer health care. Other important questions that will help you understand that person's beliefs about illness and health are, what do you think caused your illness? What have you been doing or taking for this illness? Is there something about your culture or religion that I need to know to give you better care?
You also need to understand historical factors that may be a unique trauma or stressor to the particular racial or cultural group that you're working with. If we look at the Japanese American elderly, certainly one of the unique experiences for that population would be the Japanese internment in the United States during World War II. If we look at the African American elder, a unique historical event that helped shape who they are would be Jim Crow and the whole institution of segregation.
To become familiar with a person's history, consider these factors. Where was the person born? Under what circumstances did he or she arrive in this country? Was there an experience of oppression? Does he or she have reason to be suspicious of Western medicine or authorities in general?
Another important historical factor that would be important to know about African American elders is the Tuskegee study. The Tuskegee study was a study of untreated syphilis that lasted for approximately 40 years.